This video includes the ultrasound-guided internal jugular vein puncture with 3 different approaches. Over the past decades, the increased use of ultrasound to perform the procedure has decreased the failure rate, complication rate, and number of attempts required for the successful attempt. Considering patient safety and reliability of the technique, ultrasound guidance for central line access is now primary and standard of care. To avoid risks and complications, following are the steps to be considered. Number 1. Check the equipment and its function during the preparation. Number 2. Optimize the two-dimensional ultrasound picture of the target vessel before the procedure. Number 3. Optimize the positioning of the patient in Trendelenburg position. Also, optimize the position of the examiner, the ultrasound device relative to the puncture site. Number 4. Choose the appropriate head position of the patient in order to locate the vein laterally rather than the anterior to the artery. Number 5. Give IV fluids before puncture in hypovolemic patient. Number 6. The examiner or the cannulator must have understanding of the neck anatomy as well as skill in performing and interpreting the result of ultrasound examination. Traditionally, anatomical landmarks and palpation have been used for the internal jugular vein central line access. When the landmarks are distorted by trauma or patients who have anatomical anomalies like catheter or those who have prior history of injury to the internal jugular vein, have a small internal jugular vein, or are morbidly obese, the use of ultrasound might be helpful or should consider alternative sites. If the internal jugular vein and superior vena cava is suspected with pathologic conditions such as occlusion due to the coagulopathy, should avoid the procedure. Although the internal jugular central line access is associated with higher rate of arterial puncture, it is still the choice of central line access. It is because internal jugular vein is large, more superficial, and runs a straight course towards the right atrium. Also has the lowest risks of complications like infections, pneumothorax, and inadvertent puncture of the thoracic duct. The arterial puncture can be avoided by locating the vein more laterally than anterior to the artery and by making sure that the needle is not perpendicular. Positioning is instrumental in successful placement of the central line. Place the patient in supine position. To engorge the vein and to reduce the possibility of the air embolism, patient can be placed in Trendelenburg position. But caution should be taken in case of patient with high intracranial pressure or congestive heart failure, as this position exacerbates the condition. In this video, we'd like to introduce one new landmark technique that can be used for the central line access. In this landmark technique, the imaginary line between the sternal notch and the mastoid process, the other lateral from the thyroid cartilage, these two lines should intersect at a point which roughly corresponds the position of the carotid. If a line is drawn from midpoint of the imaginary line between sternal notch and the mastoid process perpendicular to the clavicle, the lateral line from the thyroid cartilage should meet at a point. This point is the most appropriate point for needle insertion. It is appropriate to perform an ultrasound examination of the cervical region on both axes to rule out any anomaly or pathologic condition before the procedure. It is required to make sure that the internal jugular vein is patent by gently compressing the vein with the transducer. Slight pressure is sufficient to collapse the lumen of the internal jugular vein. Color Doppler flow can also be used to assist in identifying vessels and determining flow. Doppler flow can be used to further confirm the carotid artery and internal jugular vein. Then the skin is prepared with an antiseptic solution. The cannulator prepares the materials and the surgical field using aseptic technique. The ultrasound transducer is then covered using sterile sheath to avoid contamination. The internal jugular vein is relocated in short axis such that it is located in the middle of the ultrasound image. Then the needle is introduced outside of the plane at 45 degrees to the skin at midpoint of the transducer. As the needle approaches, the indentation of the anterior surface of the vein can be seen and gentle aspiration is applied. The ultrasound probe is maintained in perpendicular orientation to the neck to visualize the needle tip as a echogenic dot as it enters the vein. When the vein is punctured, then the aspiration of the venous blood confirms the intravascular position of the needle tip. Then the transducer is removed and the guide wire is introduced. Guide wire can also be relocated in long axis as it enters the vein. The internal jugular vein is relocated in longitudinal axis. The probe is moved lateral if the carotid artery is visualized underneath the vein to avoid the arterial puncture. Then the needle is introduced in plane at 45 degrees to the skin. The longitudinal approach is used so that the whole course of the needle and needle tip can be observed within the plane. After the internal jugular vein is punctured, the aspiration of the venous blood confirms the intravascular position of the needle tip. Then the guide wire is introduced. The puncture of the posterior wall of the basial can also be avoided using longitudinal view. In this approach, the probe is placed in medial to lateral direction perpendicular to the internal jugular vein in short axis, and the operator stands in contralateral side of the patient head. Then the internal jugular vein is relocated in short axis such that it lies in the middle of the ultrasound image. In case of short axis out of the plane approach, the needle tip is not often seen and could in fact have traversed back wall of the internal jugular vein into the common carotid artery, or could have been touching the apex of the lungs or other anatomical structures. These problems can be solved by this technique. In this approach, the needle is introduced at 70 degrees to the skin, immediately above the location where the common carotid pulse is felt, adjacent to the thyroid cartilage and anterior border of the sternocleidomastoid muscle. The needle is advanced laterally until the needle tip is inside the internal jugular vein and venous blood is aspirated. The orientation of needle tip is then turned less than 1/3 way, 20 to 30 degrees towards the sagittal plane. It is to make sure that the guide wire is threaded towards the heart and not to the brain. To confirm this, the guide wire can also be orientated in longitudinal axis. Then the procedure is completed using the Seldinger technique. Sterile dressing is applied at the end of the procedure.